So I welcome all of you to the first ever episode of a series of webinars to be conducted by the International Association of Ambulatory Surgery. And this series will go on for more than a year. Once in every 15 days on a Saturday evening around the same time. And today we have with me, I have my co-moderator, Marc Coppens, who's the treasurer of the IAAS. I am Naresh Rao, the Secretary General of the IAAS. And the first speaker is, no problem. So, New Procedures in Ambulatory Surgery by Luis Antonio Hidalgo Grau from Spain. He is the president of the International Association for Ambulatory Surgery. It's on to you, Luis.
Thank you, Naresh. Can you see my screen now?
Yes, perfect.
Yeah,
perfect.
Hey,
perfect.
Perfect. So, good afternoon, everyone. It is a pleasure for me to give this lecture that I had the privilege of presenting at our last Congress in Dubrovnik. Let me tell you that we are very confident to achieve a successful event today and at the rest of webinars we have scheduled. As a president of the IAAS, I would like to thank my friends Marc Coppens and Naresh for all the work they have done. My aim is not to give you an exhaustive list of procedures that will probably be included in our ambulatory surgery basket in the coming years. Anyway, we can check some examples, of course, but I think it will be better to review the essential rules for its implementation. I have no conflict of interest. As I have said, we all know that the number of complex and highly specialized procedures performed as a day cases will increase in the coming years. For a successful implementation of those procedures is an outpatient setting, we need to take into account two premises. First, preserving the quality procedures level, and second, ensuring the patient's safety. But remember, there is no patient safety without quality control and management. That means the need to establish mechanisms for quality measurement to improve care, reduce complication, and reduce cost as well. Is there a limit for procedures performed as an outpatient surgery? Where is the limit? My answer to that question is I don't know. Many of the procedures that we perform daily in our units were unthinkable just a few years ago. Let me give you some examples. Procedures that can be done in one-day surgery today and in the near future. Bariatric and metabolic surgery, fully accepted as a day surgery procedure nowadays. I can show you this article. Safety outcomes in same-day discharge.
Luis, sorry to interrupt you. We have lost your screen.
Oh, I don't know why. And now?
Nope.
No.
No?
Yeah.
Yeah.
Now?
Oh,
yeah.
Okay.
Yeah, it's okay? Oh, perfect. I'm sorry for that. So talking about metabolic and bariatric surgery, I can show you this article, Safety Outcomes in Same-Day Discharge and Anastomotic Metabolic Surgery versus Regular Overnight Discharge Protocol, a systematic review and meta-analysis. The conclusions of the article are the observed increase in mortality and morbidity among same-day patients underscores the need for stringent patient selection, standardized discharge protocols, and robust follow-up systems. Is essential patient safety, and note the importance of selection of the patients. Colon resection. Colon resection is a big challenge for us. Look at this article. Ambulatory laparoscopic colectomy is a systematic review. And the conclusions of the article, the conclusions of the systematic review are: ambulatory laparoscopic colectomy appears to be safe and feasible in selected cases with an acceptable success rate and a low risk of readmission after hospital discharge. Again, it's feasible, but with strict selection of the cases. We need to consider the problem of early follow-up when complications take place, and always to be into account the concept of patient safety. It's one. Joint replacements. Here, the anesthetic and surgical techniques are very important. One group from the Netherlands published this study, Safety and Efficacy of Outpatient Hip and Knee Arthroplasty, a systematic review with meta-analysis. And the conclusions were outpatient joint arthroplasty pathways are as safe and effective as inpatient pathways in selected populations with potential reduction of cost. So to summarize, reduction of cost, but always under safety. Another example, spinal disc surgery with a minimally invasive approach. I can show you this article, Current Trends in Ambulatory Spine Surgery, a systematic review. And the conclusions are: the results demonstrate that current focus of research emphasizes the safety of ambulatory surgery, with several studies commenting on complication rates, patient selection, and postoperative protocols to prevent readmissions or complication. Note the importance of minimally invasive techniques. Today, this is a safe surgery. Robotic-assisted radical prostatectomy. It was unthinkable 10 years ago. A new article, a comparison of surgical outcomes between outpatient and inpatient robot-assisted radical prostatectomy, a systematic review and meta-analysis. And the conclusion, this meta-analysis demonstrates that outpatient robotic-assisted radical prostatectomy is a safe and feasible option for patients undergoing surgery for localized prostate cancer. Partial nephrectomies, another urologic procedure, robotic-assisted partial nephrectomies. A new article again, day case robotic-assisted partial nephrectomy, feasibility and preliminary results of a prospective evaluation. And the conclusions were: this prospective case series is the first to demonstrate the safety and feasibility of day case radical partial nephrectomy for robotic-assisted, selected patients, and through a dedicated nurse-led clinical pathway, it provides a high level of patient satisfaction. A new one, coronary artery stenting, a very common procedure nowadays. Same-day discharge coronary intervention, how to succeed, to prevent unnecessary hospitalization and unsafe same-day discharge. Interventional cardiology teams should be trained to perform reliable risk-benefit assessments. So training of the teams is essential, and interventional cardiologists' skills are necessary. Pelvic floor reconstructions. There will be more demand in an aging society. Feasibility of same-day discharge after robotic-assisted pelvic floor reconstruction. In conclusions, in this pilot study, same-day discharge after a robotic-assisted pelvic floor reconstruction procedures appears to be safe and feasible. The procedure, I have to say, that is totally implemented in some units. To resume, let me show you a very nice article. I think its concepts are completely useful. Safety considerations with the current ambulatory trends, more complicated procedures and more complicated patients. The conclusions of the article are continuing procedural ambulatory shifts will require ongoing outcomes research, likely prospective in nature, on these novel outpatient procedures in order to develop risk stratification and prediction models for the selection of the proper patient procedure and surgery location. It revives a classic concept, patient-tailored surgery. Well, after that, let's look about the requirements for including new procedures. For including new procedures, we need fully developed ambulatory surgery units with quality management programs. We need involved and trained staff, nurses, doctors, and managers. A very good suggestion, in my opinion, limit variation among the staff. Very important for anesthesiologists and nurses. And we need to standardize operating procedures and to have pathways. And again, one suggestion, proving a small cohort of patients for testing before including the procedure. Enhanced recovery protocols. Enhanced recovery protocols, it has been a radical change since Henry Kellett's studies. One of the people who has collaborated the most in its implementation in ambulatory surgery is our friend Girish Hoshi. We need patient education. The patient and its relatives have to know how much as possible about the procedure. We have to do an accurate patient selection process that could be achieved by a good interaction between patient and professionals. That is very desirable. We can include patients ASA3 and even ASA4. And we need to consider both surgical procedure and anesthetic process at the selection. A piece of advice, schedule more complex patients early in the morning to avoid admissions. The recovery has to be as long as required. I'm sorry, not working. Now, yeah. We have today new anesthetic drugs that will be very helpful. short-acting, easily controllable. And beside that, new analgesic drugs and systems for pain control. Obviously, minimally invasive surgery favors the process. The role of robotic in ambulatory surgery will increase. And we will have new ways for early postoperative follow-up, telemedicine and e-health systems. To take home messages. New procedures will be included in the coming years as one-day cases. Not all ambulatory surgery can perform complex procedures. They need to have several characteristics. First, quality and safety. We need the standard procedures and accurate patient selection. The role of new anesthetic and surgical advances. And don't forget we are a multidisciplinary team. And I have two questions that come from Dick de Jong, that was president of the IAAS. These questions are, can this operation on these patients be performed on an ambulatory basis? And the second one, do I have to admit this patient as an inpatient for this surgical procedure? And if the answer are yes and no, do it as an outpatient setting. Don't have any doubt. And that's all. Thank you very much for your attention.
Thank you, Lewis. This was excellent presentation. We will have question answers, if any, through the chat of this Teams Microsoft, and we can move on to the next speaker. Marc, will you do the needful?
Yes. Who is the next speaker? Are you Anna or Arnie? Arnie, are you? Who is?
I am good to go, or
Yeah,
ladies
okay.
first. It's no problem.
Ladies first. So Anna has already been.
I'm fine either way.
Very polite.
Okay.
We can
Anna
try
has
once
already
again.
been introduced by Naresh. So she was the host of the an excellent international congress in Dubrovnik in May, and Anna is pediatric surgeon at the University of Rijeka. If I pronounce this well, Anna.
Yeah. So do you see the screen now? That's the most important question.
Yes, but it is a bit blurred.
It's blurred.
It's
Well,
not
I
very
don't know how I can improve
but it's
that.
readable. We can read it.
Yeah. Sorry, I don't know what's going on, but yeah. So I'm at the moment the vice president of the Croatian Society for Day Surgery, and I'm a pediatric surgeon, and I will try and tell a story of the ambulatory surgery journey in Croatia. I have no conflict of interest to declare. So, even though we always speak about ambulatory surgery as a new concept that has been developing rapidly over the last decades and has been introduced not until a little bit more than the last 100 years, I think that ambulatory surgery is a timeless practice and that people have been performing ambulatory surgery for thousands of years, long before we had the definition. Of course, the mission always remains the same, to deliver safe care, provide better outcomes, and quick return to life. Also, the definition of safety has changed a little bit throughout the past. What was once considered safe is not the same now, but the advances have allowed us to be a little more adventurous, as in real life, and also in surgery, thanks to our knowledge, developing technologies, and are willing to provide better care, always thinking of safety as the most important rule. The journey in ambulatory surgery in Croatia began a little before than 2007, but we consider the first day surgery department establishment as the first important event in the development of ambulatory surgery in our country. It was the department in one of the biggest university hospital centers in our capital city. That was like a pilot project, and it was not until a few years later that the Ministry of Health also issued a recommendation to all hospitals to follow that example and establish day surgery units and treat as many patients as possible in that way, which was followed by our national insurance health company that also tried to motivate the system by paying more money for each procedure performed according to the principles of day surgery than as an in-hospital patients. A few years later, in 2017, our society was founded, and of course, we had a huge support of IAAS, and in the next year, we were accepted as full members into the International Association for Ambulatory Surgery. With our knowledge and with the help of IAAS, we managed to have 3 national day surgery congresses until now. First 2 were held as a one-day congress. It was symbolic, an event that was held on only one day, but it was also not until the last one that we thought we have a need to have a congress in more than one day, because the interest in ambulatory surgery grew. Each of the congresses had a focus, and in the end, we are happy that we can say that we achieved some things. For example, on the first congress, it was like laying the foundations of day surgery in Croatia. It was the first time that experts, Croatian and international experts of ambulatory surgery, gathered in our capital city, that we shared the knowledge and raised the awareness of the importance of development of ambulatory surgery. The second one was strengthening practices and expanding collaboration. And we were happy to be able to say that the section of hospital dentistry was formed, and that the Croatian Society of Nurses and Technicians in Day Surgery was formed. And with all these new events, we organized the third Congress in not in our capital city, because we thought that it's important also to spread the news in other parts of Croatia. And on the third Congress, the focus was on innovation, sustainability, and the future of ambulatory care. And we focused on the importance of multidisciplinary care and on quality indicators. During the 3 congresses, there were always discussions about the definition of ambulatory surgery, and the conclusion was always that it is important to have the definition in order to have strict rules, but also that the definition should not only be translated from foreign languages, because the definition for day surgery should be adapted to our country's possibilities. So during the 3rd Congress, we all agreed to this definition, that day surgery procedure is an elective surgical intervention that requires a full operating theater facility, excluding an office intervention, and the patient is admitted and discharged on the same working day. I would say that our biggest achievement was hosting the 16th International Congress on Ambulatory Surgery, which was held in Dubrovnik a month ago. And I think it was a great success, and it helped us to be visible at the world map of ambulatory surgery, allowed us to communicate with international experts, to create new contacts, and also to get new perspectives. But in order to understand the development of ambulatory surgery in Croatia, it is important to know what our healthcare landscape is. Croatia has a good health insurance, and healthcare is available to everyone. So we have a historically traditional hospital-centered model, and care has traditionally been delivered in hospitals, with inpatients being the primary focus of the system. The public system is dominated by the Croatian Health Insurance Fund, but since we are quite an old population, we have long waiting lists, and that gave the opportunity to private sector to grow. So along with the development of the private sector, also the public system and the public center realized that we also have to shift toward ambulatory and day surgery care. Along with the system, also the country's special shape and characteristics has to be had in mind when organizing healthcare. Our country has a special shape, has long coastline, many islands, and some mountain areas which are quite difficult to cross in winter. So many communities have to travel to larger centers through some areas that are not so close to the hospital. And that means that in our country, day surgery cannot be applied to everyone, and cannot be the same everywhere. So we have to be sure that we give the right care in the right place for the right patients. There is a difference between public and private healthcare in Croatia, because the public sector, as I already said, has longer waiting times for examinations and for the procedures. And in the private sector, this access is quite faster. Public sector has large hospital systems, but private sectors are usually smaller hospitals, but sometimes have modern infrastructure, more modern than the public hospitals. Also, public sector focuses on universal access, while private sector sometimes tends to attract patients from abroad and deliver medical tourism. But both of the systems have the same goal to get better healthcare for every patient. That is why in our system we need to have strict rules on the best selection of patients and on the whole process. The procedures that can be performed in ambulatory surgery in Croatia at the moment in public healthcare are controlled by our health insurance company, which issued a log of procedures. Currently, there are 111 procedures that are allowed to be performed through ambulatory surgery in public system. Of course, that is not the final list, but not every procedure can be added without special requirements on the log. In private sector, it is a little bit different. The private hospitals choose which procedures they can perform in their hospitals. We do not have country-specific guidelines for day surgery. We have planned to write our own guidelines, and we will definitely do it in the following period. But of course, we do follow some recommended guidelines, which we took over from the existing ones. Also, we acknowledge the importance of the strict discharge criteria, but we don't have unique discharge criteria lists when discharging the patient from the hospitals. The growth of day surgery in Croatia, this is like a projection of the growth of day surgery in Croatia, which shows that our numbers are not so high as in developed European countries, but it shows slow but steady growth, which shows that I think we can say we are playing it safely, and that's the only right way to do it. We hope to reach our target by 2030, but we will see how this will work in the future. In order to fulfill the plan, of course, and to follow our vision, we need to have a good plan, which definitely should start with protocols, and then with the usage of these protocols. We have many specialist societies which should have better collaboration than they have now. We should organize special topics, workshops, and build a strong community of professionals to support and grow together. We have started a good communication with the government, but we plan to continue it because the government must be aware at all the time of the importance of ambulatory surgery, and of course continuous evaluation and national registries are important to monitor outcomes, measure results, and use data to drive continuous improvement. Of course, to follow the plan, we will be of great use with freshly issued international manual of ambulatory surgery, so I recommend to everyone to read it and use it. And of course, together we are shaping a future where ambulatory surgery in Croatia is safer, smarter, and more connected, and centered on better care for every patient. So, to conclude, I send you a sunny greeting from my hometown. Thank you.
Okay, thank you, Anna, for this nice presentation. You can be sure, Anna, that we had a good congress in Dubrovnik, and it was very fruitful. And the proof is this series of webinars. I think that's the best proof that we had a good congress in Croatia. I propose to take the questions after Arne's presentation. Dr. Arnaldo Valedon needs a little introduction. I think he is now the past president of IAAS. He did a fantastic job past 2 years. And now he will give a talk on ambulatory surgery throughout the world. Please, Arne, go ahead.
Thank you very much, Marc, for the kind words. Can you see my screen?
Yeah, perfect.
Yeah. First and foremost, I need to echo the sentiments from Marc and profusely thank the Croatian Society and Anna for the phenomenal congress that we were able to put together in Croatia. Very, very proud and thankful for everything that you did. For those of you who I have not met, my name is Arne Valedon. I'm the immediate past president for IAAS. And I practice in the United States, originally from Puerto Rico, and I've been practicing outpatient anesthesia and perioperative medicine for about 29 years now, almost 30. So what I just have a couple of disclosures, a literature review for ARC Medical and a survey for Acacia Pharmaceuticals, nothing that will influence the presentation today. And what I like to do in the next 15 minutes or so is a few things. Number one, I extend on the patient safety and outcomes data that Louise and Anna presented already, and also decipher how is it exactly that each of us define clinical excellence and how exactly do we define safety? Because it is a term that a lot of people use, but it might mean many different things to different people. And also very important, just go over some of the global trends in day surgery that we're seeing currently. Starting with definitions, a lot of debate recently actually among the membership for IAAS regarding the definition of ambulatory surgery, but it needs to be clear for each of our countries what we mean by that. It could, again, as an example, an admission less than 23 hours and 59 minutes as opposed to a working day that has been in debate. The official definition that IAAS has used has been a working day as opposed to 23 hours. But I want to highlight it because when you look at the data regarding outcomes, you have to make sure that you understand how is it exactly that the outcomes are being defined. An ambulatory surgery center, typically defined as a freestanding facility that is offering surgical and procedural services that do not require hospitalization and does not give care for more than 23 hours and 59 minutes. Hospital outpatient departments, this is typically a term that applies to the United States only. And in terms of licensing and regulations, they are treated differently than an ambulatory surgery center. Clinically, very, very, very similar. But again, when we look at data, we need to make sure where the data is coming from. And these are hospital operated pavilions, but when you look at them, they look exactly like an ambulatory surgery center. Then office-based surgical facilities, which are facilities that are not licensed as a ambulatory surgery center or a hospital outpatient department. They could easily, of course, and typically are freestanding facilities. But in terms of data, and that is a question that I have for Anna later on, in terms of data, we need to make sure that we're not, that we have them in the right bucket, right? So we can speak truthfully with evidence behind it about outcomes. And then when we look at facilities in Australia, as an example, we have day surgery hospitals and short stay hospitals. They are different regarding the length of hospitalization. For day surgery hospitals, less than 23 hours and 59 minutes. Short stay hospitals, could be a brief inpatient stay, typically up to 5 days. So again, I just want to make sure that we take note of what is it exactly that we're looking at when we talk about outcomes. Now, let's talk about safety. And this is something that, again, I'm a fan of definitions. And when you ask different people, well, what does safety mean to you? Does it mean that you have less mortality? Does it mean that you have less morbidity? And what exactly does that mean? Well, when we look at the dictionary, safety is defined as freedom from accidental injury due to medical care. Very, very general definition. At least in the United States, the Center for Medicare and Medicaid Services has a more focused definition, and it is stated over here on your slide, is delivering surgical and anesthesia care in a same-day setting with minimal risk of complications, rapid recovery, and safe discharge, supported by systems that prevent, detect, and respond to perioperative risk. So it's a little more honed in definition. And again, something that we must take into consideration for when we discuss outcomes. Suffice it to say, there are some core components of medical safety, and error prevention, of course, is at the center of it. Risk reduction with protocols and screening and monitoring. The system design. What is it exactly that we're trying to design so it's not based on an individual alone? A cultural safety, being able to speak up freely and identify potential hurdles and problems for the system, and then of course continuous learning for the system. So again, very important core components for any safety system. And if we want to apply that for day surgery alone, I think we can all agree that selecting the right patients and delivering reliable care that is complication minimized and with a safe discharge in a high efficiency environment can be used. Let's look at some of the compound growth rate by region around the world. When you look at this map, and again, this is coming from Mortar Intelligence, a very sophisticated and trusted source of consulting around the world. Countries with more mature markets like the United States, the UK, Australia are likely going to have a more of a medium to low growth rate because it is a more mature market. But right now, Asia Pacific and Africa, according to Mortar, has the highest CAGR, and this is calculated to 2030. So it's an area that, again, we need to pay close attention to and be able to help as much as we possibly can. When we look at the factors that contribute to the geographical variation, I would say they mostly fall into these 6 buckets: payer and provider consolidation, third-party payers by insurance, population growth, and certainly the cultural adoption of day surgery, for sure, not the same around the world. Physician alignment. There are, again, many physicians around the world who still don't feel comfortable with day surgery. Many others who would like to do everything they can possibly do, of course, as outpatient. We also know that each country, each state, and each township really will have their own regulations for day surgery, and that will contribute to the geographical variation. Entrepreneurial activity, very important, certainly in countries like the UK, the United States, we're seeing a lot of it, and competition from private equity and large management companies into day surgery. So they all contribute in some capacity to the variation that we see. So let's look again at some of the markets around the world. The largest market so far, we continue to see North America to be leading it. The fastest growing market, as I mentioned previously, Asia Pacific seems to be leading the charge. And the overall rate that is being calculated for around the world, again, is about 5.6% for that compound aggregated growth rate. So certainly not a amount of business and care that could be ignored. By 2030, it is expected to be about $110 billion. Now, when we look at the drivers, again, that are affecting the market trends globally, the rise in demand for outpatient surgeries tend to be in the top three drivers. Also, AI-enabled workflow optimization is rapidly growing. So we're trying to see that. That's going to be more of a long-term impact. And then patient convenience and expansion in emerging markets. Again, as the population becomes more familiar and more comfortable with the concept of day surgery, we expect the market to grow even more. Talking about the United States, the type of ASC covered procedures, another question that I have for Anna down the road, tends to be increasing. And as a matter of fact, we no longer have a inpatient versus outpatient list, according to CMS. A huge change compared to 30 years ago. Also, the regulations that are needed to establish a surgery center tend to actually be decreasing in some areas of the United States, which certainly is helping to increase the growth rate. And again, the adoption of high deductible plans, something that is we're seeing in Europe for sure, North America for sure, and certainly a huge driver for a less expensive environment. When we look at our restraints, again, globally, is fair to say that the high initial setup cost are setting a hurdle for restraining growth. And also the shortage of skilled healthcare professionals. And when we say skilled, that could be, again, providers who are not necessarily used to having patients discharged on a day surgery basis. And then for the United States specifically, the reimbursement, the difference in reimbursement between an ambulatory surgery center and a hospital outpatient department tends to restrain the growth. That is a difference that is shrinking very quickly. And also for the United States and Canada, a massive shortage of providers in anesthesia and peri-op nursing. So important restraints and important analysis. This is, again, a 10-year forecast for the United States, looking at the markets from 2023 until 2033, and kind of a complicated slide, but what I like to point out is that there's still, when you look at the hospital, outpatient, and ASC volume, that is projected to continue to grow by about 11%. And when you look at the far end of the curve, care at home, it's a hospital at home is what is called officially over here, is also projected to be on the rise. This started with COVID and it has continued to be a main driver for forecast. So in essence, ambulatory surgery, day surgery is not planned on or projected to be slowing down anytime soon. It's here to stay. So some of the disruptors that we're seeing, having corporate chains are expanding fast. The USPI, AmSurg, and SCA management companies are certainly disrupting the market. Private equity, the insurers going vertical. Insurers like, let's say, United Healthcare now owning chains of ambulatory surgery centers. That really changes the reimbursement, it changes the market. And also physicians becoming more entrepreneurial. It is legal with many restraints, but it is legal for physicians in the United States to actually be owners in surgery centers. And that has also contributed to the rapid growth. Some of the financial themes and regulatory themes that we see around the world, again, licensure and oversight. Most countries do mandate some type of licensure with unannounced audits. Financial controls, again, that's a leverage that many third-party payers will use. Accreditation, they're completely variable around the world. The United States alone is heavily restricted. And then quality reporting, which is, again, at different levels in different countries of the world. On the clinical side, as Luis and Anna alluded to, interesting enough, what we have seen in the past 30 to 40 years is that day surgery has become more of a exclusion type system. And what we mean by that is that at the beginning, we included a small number of people into day surgery, but now most patients are hopefully considered to be outpatient until proven otherwise. And again, at the very top of the criteria that we need to use is patient selection, and we'll talk a little more about that. But this is the bird's eye view, really, for the clinical realm of day surgery. What we saw in the early 2000s, again, were minor skin procedures, arthroscopies, have now changed into robotic surgery. As Luis alluded to, more complex lumbar fusions, for example, three-level cervical fusions, now more mainstream. The largest section of the market for the United States has been cardiac procedures. That is certainly, and not just pacemaker battery changes. We're talking about ablations. We're talking about, again, all sorts of trans-arterial and transvenous procedures being done. So an area that needs a lot of monitoring and outcomes analysis. But complexity continues to increase. And in summary, when we look at day surgery, what is it exactly that has made it grow the way that it has? And I would mention to say that clinical excellence has been maintained across all practice settings, whether you're talking about an HOPD or an ASC versus any kind of freestanding facility. We know that safety, when it comes to number of complications, mortality, has been maintained, and that's what the data shows us. Also having ARF protocols, as Luis alluded to, and being able to transfer some minor tasks from the healthcare providers to family or other caretakers has been successful. And no doubt, having technological improvements and minimally invasive techniques has certainly allowed for substitution of surgical settings, and also very important, financial and regulatory incentives and pressures. Just a little more data apologies for that. That shouldn't have happened. Sorry about that. So this is a fairly large study that spanned from, it was a multi-year project, but had close to 200,000 patients. And these patients were ASA 3s and 4s, certainly not the healthiest of the bunch. And what it showed us was that the same day discharge was not associated with higher morbidity, readmission, or mortality. The 3-day mortality rate was about 0.037%, and 30-day mortality 0.13%. So certainly led us to lower adjusted odds of complications compared to overnight surgery. And another study, this is from 2005 until 2018, with over 6.4 million procedures. This is part of the American College of Surgeons, and also showed lower adjusted 30-day mortality and overall morbidity. So patients treated in an ASC were less likely to be admitted to a hospital or visit an emergency room on the same day or 7 to 30 days after surgery. So certainly not a lack of numbers when we look at data. We have, and by the way, I have all of these references over here for you in case you're interested in looking at specific sections. But on particular study over here on the left, similar post-op complications for day surgery compared to short stay units for procedures including laparoscopic cholecystectomies in adults and children and percutaneous nephrolithotomies. Also, another study looking at short stay programs and also showing that the same day discharge did not may not lead to readmission or neurovascular injuries, as well as DVTs. And then for total thyroids, again, another study showing that there's a lower rate of 30-day complications, including death, compared to inpatient procedures. And as Louis showed before, total shoulder arthroplasties also showed the same. Another summary of there's fairly specific procedures: gallbladder removals, hip and knee arthroplasties, mastectomies in high-risk general surgery. All of these studies, and there are 6 different studies that we looked at here, showed pretty much exactly the same. That these procedures being performed as day surgery cases are just as safe as short stay procedures or longer readmissions and complication rates. So overall, what the evidence shows us is that for carefully selected patients, and I need to absolutely emphasize that day surgery is at least as safe as short stay alternatives. In some instances, such as infection rate in DVTs, as an example, we have shown similar or even slightly better outcomes. So patient selections, key consideration, including ASS status, home support is absolutely crucial. And the complication rates consistently range between 1% to 5% with no evidence of higher risk, and there for sure cost advantages to having day cases. So thank you very much. I know each of these topics we can spend hours discussing, but I thank you in advance, and I look forward to the Q&A.
Okay, thank you, Arne, for this very nice review of day surgery around the world with different organization models and different types of care as well in different units. Arne, you have some questions for Anna?
I do. So Anna, I was wondering, in Croatia, you did mention that there were 111, at least 111 procedures that were approved for day surgery.
Yes.
Who is in charge of accepting those procedures, and what are the criteria that are being used?
When I did the first draft of the lecture, there were 73 procedures. That was a few years ago, and then over the years we added a few more procedures. So each specialty has a society, and at their meetings, when they think that another procedure should be added to the list, they write a proposal, and then it goes to board. And if it is accepted, then it is added to the list of the procedures. So it's basically the communication between the specialist societies and the insurance company.
Okay.
Of course, there is also a member of the Ministry of Health involved, because it should be also discussed with the specialists, but we are talking about the public sector, of course, because in private sectors it is a little more liberal. You can do whatever you want in private sector. Nobody will control you, but then you are responsible for your decisions. But in public sector, it is like if you perform a procedure that's not on the list, then the insurance company will not pay you for that procedure.
So
Yeah. go
No,
on.
so I'm happy to hear that there's a fairly large input from clinicians
Yeah.
into that list. I get very different from the United States. That list of inpatient versus inpatient is strictly, essentially controlled by the Center for Medicare and Medicaid Services by CMS. But interesting enough, that inpatient only list has gone away. So now it's any patient essentially within reason, of course. I mean, that doesn't mean clinically that any patient should have day surgery, but in terms of, as an example, total hip arthroplasties was one of the last procedures to migrate a few years back. But now we no longer have that list. The other question that I have for you, which you mentioned, had to do with having office-based interventions. Is there anybody or any entity within Croatia that keeps track of those percentages of office-based interventions?
No.
And how about regulations for those office-based facilities?
Well, it's I'm not sure how to answer your question, but in the I deal more with the public sector since I work in the public sector, so it is more strictly regulated. And the private sector is like a business of their own, but they also the procedures are basically the same that are done in the public and private sectors, because it's mostly the doctors that work in the public sector, and in their extra time they work privately. There are not many specialists that work just in the private sector.
Yeah, this is an area that I think for the IAAS in the future we should probably look at. The trajectory of office-based interventions in the U.S. has gone like tremendous change, because it used to be, very little regulation, very little oversight. That is no longer the case, because many of the procedures that are being done in an office, what we consider an office-based locality, could be the same was what is being done. So it does need oversight. We do need to take a look at outcomes and evidence for that. So I was just curious to see if there was anything else. So sorry to take too long, but I was just curious.
Arnie,
yes,
can you give some examples of typical procedures that are being done in office-based surgery units in the US?
Sure. Procedures like lithotripsies, as an example, where there are several companies that bring a machine, the lithotripsy or an S-wall machine, into the office. They treat the patients, general anesthesia, and then the procedure goes away. I mean, that's typically a procedure that you see done in a hospital or an ASC, but it's been definitely done in an office-based procedure. Plastics. Augmentation mammoplasties, facial facelifts, liposuction, very commonly done in office-based procedures. And again, all of those are under general anesthesia, as you well know. So those are just examples right now. Interesting enough, the way in cardiac is expanding very, very quickly here. And in terms of regulations are catching up. And they are in a bucket of ASC / office-based laboratory. It's a brand new category. Of course, there's a lot of oversight over this, but in terms of when you look at the data and it says office-based, well, should we include that in it? Well, I don't know. So we got to be, we have to be careful with that. But those are just examples. So it could really be, could also be a cyst on your thumb, but it's not always. So.
Okay. Are there any other questions from the audience? You can put them here. You can put them in the chat. Otherwise, I have a question for you, Luis. If I understood it well, the first study you presented showed an even increased mortality for obesity and diabolic surgery. Am I right?
Yes, you are.
Yeah, I think
Yes, you
it's a bit worrying to see a higher
Yeah.
mortality. It was a systematic review.
Yeah.
What was the reason for mortality, and how should it be able to tackle these reasons?
Yeah, the key point is patient selection. You need to select the patient very carefully because it's the way to avoid postoperative complications, even admissions or some kind of things.
Yeah.
And the conclusion of the article enhances that you have to select the patient before to decide to do it in ambulatory setting. Yeah. And that's why. That's the difference.
But is it only a matter of preoperative selection, or is there something to say about home monitoring of vital signs? And Arnie talked about systems that prevent, detect, and respond to perioperative risks. Is that the way to go in the future? Should we monitor vital signs? There are a few pilot projects in Belgium right now.
I agree. There is a very nice article from the Netherlands, I think 2 years ago, about telemedicine, about home monitoring after metabolic surgery. In my opinion, that's at the moment too expensive for a lot of countries, but I think it's the future because the use of telemonitoring or home monitoring is going to provide more safety to the patient and to the clinician, both. And yes, I think it will be the future. But nowadays, there are not a lot of countries that can do it.
Well, I think it's only now a few pilot projects here and there which are going on. Arnie, what is your idea about home monitoring?
So interesting enough, this has been ramping up now for several years, and specifically to metabolic surgery. There's some large trials out of Israel, actually, with a device called the OWL, OWL, that specifically for patients with sleep apnea, just detecting obstruction, detecting desaturations, detecting disrupted breathing. It makes a difference. It makes a huge difference, of course, for home. The question is, once you detect it, what can be done about it? Because what I see as oxygen saturation, let's say 70% in the middle of the night. Who's gonna wake up who to make sure that the patient is doing well? So it's a complicated topic, and the fact that you can measure it is not the end point. The end point is, what are you going to do with that data? Who will be responsible, and will it matter in the end? Because patients do well. We know that over time, right? That's what the data tells us. So what exactly are you adding, right? So now with AI-driven protocols, this is only going to explode even more, right? Who's going to be at the highest risk as we go? And is that for a physician on call to do something about it and make sure that the patient, takes a deep breath or moves or gets up or whatever? It's a fascinating topic to me. I'm a strong believer in that. I just don't know that I have the solutions for it.
Yeah. In the future, we will learn more about that. That's for sure.
Maybe robots. I
Yes.
don't know. I mean,
Yeah.
for $29,000, you can buy one yourself, right? So,
Yeah. In my hospital, Luis, the urologist is waiting for the single port robot to start with partial nephrectomy in day surgery. Is that a newcomer in the surgical world?
I think we need to wait because at the beginning, when we began to use single port, we thought it was the final solution. Excellent. And now results are not so satisfactory. So we need to wait for that. It's a possibility, but in some cases, not always. I'm not sure it's going to improve the postoperative recovery. I'm not sure about that. And it's technically demanding, obviously. It's technically demanding, yeah.
Only I was quite surprised to see that the thyroid is even more safe as a day case. I remember a few on-calls that I had to run to have patients on the operating table for bleeding.
Yeah.
So that's a very interesting study, actually. Just the way that it's being done. I mean, something that we haven't really talked about much or analyzed is which providers are actually doing those cases, right? So somebody, I think we would all agree, a surgeon who has been doing thyroidectomies for 25 years, as opposed to a resident. And again, we have to look at the whole spectrum, but what is it exactly that is included in that cohort of patients? And it will matter, right, in terms of long-term complications, but that has been well established. I mean, the main concern when it comes to total thyroids is, of course, calcium control and all of that. So, but as long as you have well-established protocols and ionized calcium, within a specific range decided, those patients, if you're within normal range, at that point, you're going to be within normal range longer term. And I think that's a main difference, for all the studies that have shown complications, is where not everything is being measured the same way. So again, patient selection at the start. So.
Yes. Before the operation, you have to select before. Before.
In my hospital, we still keep the thyroid 24 hours on the post-anesthesia care unit. So we have a lot to do in Belgium, I think.
Have you? Sorry, no, because I'm curious. Is there a high rate of complications for those thyroids, or does the majority end up going home with no problems?
No. We in my hospital have a lot of experience about that, and we have excellent rates. We have less than 1%, and always minor complications. So I think it depends on the skill of the surgeon. The first is the first step, and after that, obviously, controlling postoperative calcium and that kind of things. Yeah.
So and how long do they stay in the hospital, Luis?
No more than 6 hours.
Remember,
because
yes, the definition.
No. I mean, the major complication that you can have in a total thyroidectomy is cervical hematoma, and usually cervical hematoma occurs not more than 6 postoperative hours after the surgery. Yeah. So you can be sure about that. I have to say we have not any case of postoperative cervical hematoma at home. We have not, and we do a lot of thyroid and parathyroid surgery. Yeah.
Okay. Thank you. So, are there any more questions? Naresh?
So I think this is the first step that we have taken and started the IAAS webinar series, and I'm sure the popularity um, will increase in leaps and bounds in the future one. The next webinar will be on the 4th of July, and I will be sending the details in a couple of days to everyone. I thank all the participants and a few who have logged in to to this historical webinar, and I hope that you will be with us in the future webinars also. Yes, Marc.
Well, I can say that the manual on ambulatory surgery edited by Hiroshi, which was introduced during the Congress, is submitted for publishing with Amazon, and it will be available in less than 72 hours. And every webinar we will remind you on this topic, but it is coming soon now.
Fantastic. Fantastic.
Yeah.
Well, thank you, guys.
Very good.
Yes.
Thank you.
Thank you very much.
See you on 4th of July. Bye-bye.
Bye.
Perfect.
Bye.
Bye. See you.
Bye.
Bye-bye.
Bye.
Bye-bye.
Bye, David.
Bye.
Bye-bye. Bye-bye. Good to see you.
Bye.
Is it hot in England? Oh, he left.
For sure it is.
That's everywhere. Bye.
Where is Popsy? What happened to her? What happened? யார் இது? What soup? Little bit, very little. You don't want to eat much. I love very little soup. And of course, my daughter has bought chocolate cake for me. I need that only.
She has got her a vegan cake.
This one, huh?
Cheesecake, yeah, vegan cheesecake.
So how was college, baby? I had a horrible day today.
So what happened to your case?
I wanted to do hemorrhoidal artery ligation.
Hemorrhoid?
Artery ligation, huge hemorrhoids. Hard hemorrhoids. அதுக்குன்னு பெரிய ப்ராக்டோஸ்கோப் போட்டு 10 centimeters உள்ள into the rectum. I just at that arterial place அப்படியே scoop. I have the habit of going inside the rectum and manipulating and taking the sutures. எடுக்கும்போது நீடில் உள்ள போயிடுச்சு பாரு. அது உள்ள போயிடுச்சு, இது வந்துடுச்சு வெளியே நூல். And we couldn't locate it. அப்புறம் சியாம் வச்சு அடிச்சாக்கா உள்ள இருக்கு. எங்க ப்ராஸ்டேட் கிட்ட போயிருக்கு. அப்புறம் செங்குட்டுவன் my radiologist came. அல்ட்ராசவுண்ட் உள்ள போட்டு ஏனல் கெனால் உள்ளே அந்த வெஜைனல் ப்ரோப போட்டு அத உள்ள போட்டு அது பண்ணி மேல இருந்து ஒரு ஸ்பைனல் நீட்ல போட்டு லோக்கலைஸ் பண்ணி அப்பவும் கிடைக்கல. Then we opened up the intersphincteric space ஓபன் பண்ணிக்கிட்டே உள்ள போனோம். உள்ள போனா அதுக்கப்புறமா சியாம் அடிச்சு 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 அத நீட்ல புடிச்சு அப்படியே மியூகோசாவுல தள்ளி அப்புறம் வெளியே எடுத்து 3 hours ஆச்சு. நார்மலா இது வந்து என் தப்பா இருந்தாக்கா மற்ற சர்ஜன்ஸ் எல்லாம் லபோஜிபோன்னு கட்டுவாங்க. ஏன்னா மை டைம் வாஸ் 7:30 to 8:30 தேட்டர். பட் 11 o'clock ஆச்சு முடிக்கிறது. ஓல்ட் டேஸ் மேன். இது தனியா வந்துடுச்சு.
தனியா வந்துச்சுன்னா another for future இது. Whenever we are doing inside the cavity, அந்த இதை வந்து விடக்கூடாது till the time you
அதுக்கு அப்படியே வந்துடுச்சு அது. நான் எப்பவுமே அதை விட்டுட்டு இந்த சைட்ல இருந்து எடுப்பேன். நைட்மேர் வெளியே எங்கன்னா என்ன ஓப்பன்ல இருந்தாலும் பரவாயில்ல, லாப்ரோஸ்கோப்ல இருந்தாலும் தேடிடலாம். இது விஷனே இல்லாம ஒரு டனல் உள்ள. We told everything. One small bit caught inside and then later ஆச்சு எடுக்கிறதுக்கு.